Well, thank you very much. That was a fantastic film, and I'd like to welcome everybody here today. I'm going to be chairing today's event. I'm Jim Hume. I convene the National Rural Mental Health Forum, which obviously has an interest in rural health, specifically mental health, of course. That's run by the mental health charity Supported Minds Scotland, which is a large footprint in Highland region, having centres in Allness, Golspie, Inverness and Fort William itself, and also runs the Distress Brief Intervention, or a partner in the Distress Brief Intervention project across the Highlands and Islands region. So very warm welcome to everybody here today. We have a great lineup for you, and we'll go into everybody in a moment. But firstly, of course, the title is Leading Rural Health, and can I just say happy birthday to the University of Highlands and Islands, and here's to the next 10 years and many more after that. UHI and of course Highlands and Islands Enterprise really benefit from their coterminous boundaries and the fact that they're in a prime position to lead our way out of post-COVID crisis and into recovery and a better future than we've perhaps had in this last year. Presentations are going to last about 40 minutes. There will then be a panel discussion from some experts that are here today, and then we'll have audience questions and answers also. So you should have in front of you a Q&A, so if you do have any questions, do pop them in there at any time. Your cameras and microphones are actually turned off for the event. You can also avoid any personal data if you not want to be recorded, because we shall be recording this event today by just writing guest in place of your name. As I said, we will be recording this and it will be going up on the university's YouTube channel within the week or so. So thank you very much for that. This has been a series of events, and we do have another event which you can sign up to, and you'd be very welcome to. That's at uhi.ac.uk/events, and that's on the 13th of May at 4 p.m. So enough from me. I'll just briefly introduce all of the panel and the presenters. Starting off with the panel, we have Professor Arthur Steiner, who's recently received his professorship, so congratulations to yourself, Arthur, from Glasgow Caledonian University. And he's a professor in social entrepreneurship and community development. So welcome to you, Arthur. We also have James Cameron with Highlands and Islands Enterprise, who is the head of life sciences and inward investments at Highlands and Islands, as I said. Old friend of my own, Dr. Kate Stephen, behavioural scientist at SOUC with interests in animal diseases, but also health and rural mental health. So welcome along here today, Kate. And the final panel member is Moira Mckenzie. She's the Director of Innovation and Deputy Chief Executive Officer at the Digital Health and Care Innovation Centre. As for our speakers in reverse order, speaking on online art therapies, we'll be hearing from Dr. Anya Zubala, Research Fellow, Division of Rural Health and Wellbeing. We'll also be hearing about social prescribing for health and well-being in rural areas, something I think we can do more of across Scotland, but in particular in rural areas. And that's Dr. Anna Terria, who's a research fellow at the Division of Rural Health and Wellbeing also. We will hear from Dr. Jenny Hall, also from the Division of Rural Health and Wellbeing, about reducing amputation through remote monitoring. And we will also have Dr. Hannes de Kock, who is a research fellow with Division of Rural Health and Wellbeing at Highlands and Islands and a clinical psychologist. And Hannes will be talking about supporting NHS workers with their mental health through digital intervention. And to lead us off is another recent professor. Congratulations on that, Sarah Ann. Very pleased to hear that. Professor Sarah Ann Minoz, who from the University of Highlands and Islands, who will be talking about the designing sustainable rural health services. So, Professor Minoz, over to you. Thanks.
Thanks very much, Jim. It's a real pleasure to be able to kick off the series of presentations this afternoon. We're going to, as Jim has outlined, look at rural health research, which has been led by the University of the Highlands and Islands. As an organisation, we've been working in rural health research for, I think, something more like 15 years. So it all started when we were at the UHI Millennium Institute. And now, 10 years into having the university title, there's really a breadth of work going on across UHI that relates to the health and well-being of people living and working within our rural environments. And that's from work which considers how we can effectively design and deliver statutory health and care services in rural areas, through to work that looks at the role played by our community and voluntary sector in promoting rural health and well-being. And our research often looks at finding new ways to deliver rural health and care services, such as through technology and new professional roles, such as community link workers. So we're going to hear about some of these themes during the course of the presentations. They're really designed to give you a flavour of some of the different types of rural health research that have been carried out at UHI. We hope this is interesting for you, but also could act as a provocation for ideas and discussion after the presentations, particularly around how the type of social science research that we carry out can help support our remote and rural communities, how it can contribute to sustaining service provision and link with industry and the third sector. And Jim's outlined these topics that we're going to focus on today. These are examples from the work carried out at the Division of Rural Health and Wellbeing, and we're part of the UHI Institute for Health Research and Innovation. And what we're doing today is hearing from the researchers themselves who've been involved in leading this work. So as Jim mentioned, I'd like to kick off by giving some illustration of work that we've done around design and evaluation of rural health services. So the statutory delivery of services in remote and rural areas like the Highlands and Islands can be challenging, and that's not least because of our large geographical area, also our dispersed population and our ageing demographic. And as I mentioned before, this can lead to us needing to do things a bit differently. And one of the ways in which our researchers have tackled this is by looking at how rural citizens themselves can be successfully involved in the design and the delivery of rural health services. And there's lots of benefits to this type of engagement or this type of participation. Rural citizens and indeed rural frontline workers, healthcare workers, are often the people who are the experts in what their communities need. And by involving them in the design process, you tend to get services that are more locally appropriate, that can be more cost effective and more sustainable in the long run. And our research has shown us that sustainable healthcare services have wider impacts for rural communities. And that's because they're integral to things like a rural community's sense of sustainability, their sense of resilience and of identity. But our research has also shown that there can be a bit of a mismatch sometimes between the policy that comes, for example, from Scottish Government level and the experience of engagement on the ground in rural communities. So through our qualitative research, we can see that there's a real breadth of opinion on participation and engagement in rural health services design. And to illustrate this from the health services side, we can see that these views range from people who feel that community engagement is actually unfeasible, through to people who feel it is feasible but needs to be carried out within very defined parameters, through to those who feel it really is the role of statutory organisations to support communities to participate. And from the rural citizen side as well, we've seen a real breadth of opinion. And views range from those who feel there are good structures in place to allow community voices to be heard within services design, through to those who think engagement structures are there, but that community opinions perhaps don't influence statutory decision making, through to those who feel that engagement activities are actually tokenistic. So what we know from our research is that involving citizens in healthcare design and planning can help us build sustainable services and healthier communities, but what we need is the tools in order to facilitate this kind of engagement. So I wanted to reflect back on one of the first pieces of research that UHI undertook in relation to citizen engagement in planning, which was called the Remote Service Futures Project, which was led by Professor Jane Farmer, who was our first Professor of Rural Health. And this project developed a new way of engaging rural communities, healthcare professionals and service providers in planning through serious gameplay methodology. So it allowed these different actors to come together to collaboratively redesign their primary care services in a way that they felt was appropriate to their local context. The game itself uses an anonymised community budget and information on healthcare practitioner roles and their skills. And that's in order to facilitate a collaborative planning process. So the serious game was really intended to be a starting point of a conversation that would ultimately result in a feasible health and social care design for future implementation. So we tested this with 3 remote and rural communities during our research, and one of them used the process to redesign primary care, including the use of new roles such as the community first responders. So we found it was possible to design a serious gameplay methodology that facilitated a non-confrontational process of service design that meaningfully involved rural community members. And Professor Farmer took this beyond the Highland context and successfully used it in 6 communities in Australia, where they also were able to prioritise community needs and develop costed plans for their own sustainable service delivery. And over the years since the Remote Service Futures project, we've been able to take the knowledge gained from that and to build on it through many other projects. And this has been in work that's facilitated collaborative co-design of services and also facilitated the participation of community members in service design and delivery. And we've also drawn on this in work which has developed ways to monitor communities' perceptions and communities' experiences of engagement and participation, for example, through the development and testing of indicators to measure change in these areas. And lastly, I can move on, yeah. Lastly, I just wanted to mention that we're currently engaged as part of an NHS Highland technology-enabled care project. We're one of a few Pathfinder projects within Scotland to look at redesigning the respiratory care pathway. And we're leading on the stakeholder engagement and contributing to the co-design of a new patient-focused pathway for respiratory. So what we're doing is using our expertise as social scientists to understand the current pathway and then to engage stakeholders to capture their needs, explore their priorities, help them to identify solutions and to pilot and to test those solutions. And this is with the aim of moving towards, as we say, a more patient-centred pathway within the respiratory area. So hopefully that's given you an overview of some of the work around service design and community engagement and participation. And what I'm going to do is to hand over to one of my colleagues, Dr. Hannes de Kock, who's going to talk a bit more about mental health and digital intervention.
Thank you, Sarah. Right. Yeah, so I'm going to be talking about the current state of NHS Highland staff, and then I'm going to be talking about a digital intervention that we designed to support their well-being through this COVID-19 pandemic. I am a research fellow here with UHI, and I also work in the NHS, so this is quite close to me. And also some of my research interests are aligned with burnout and resilience. Yeah, so basically we're going to just be covering 3 parts of a project that we've been busy with over the last 6 months. Firstly, just going to speak about understanding the impact of COVID-19 on frontline staff globally. And then we're going to just speak briefly about what we found to be the psychological or mental health of staff here in NHS Highland and the changes over time. And then thirdly, we're going to speak about an app, a digital intervention that we developed to support staff well-being during this pandemic. So this slide just provides us with a bit of an overview of the whole project. We're going to be starting off by speaking about a review, and then the baseline study, and then the 3-arm RCT that we tested our intervention with. So just to start off, we had to review to see what risk factors there were for adverse mental health outcomes, and we actually published a paper on that in BMC Public Health. In short, what we found was that working in close contact with COVID-19 was deemed to be a risk factor, as was being a nurse, heavy workload, lack of PPE, fear of infection. But there were also some protective factors that mitigated against adverse mental health outcomes, and they were notably support, and the support can be from community, social team, or government, but also on an interpersonal and intrapersonal level, we found resilience to be a protective factor. So we concluded that if you wanted to design an intervention, focusing on resilience is probably a good thing, but not at the expense of also addressing environmental and systemic factors. So the second part, call this the longitudinal baseline phase of assessment. We really wanted to employ a longitudinal design to look at the mental health of health and social care staff in NHS Highland over time, because you get more certainty from your results, and you can also allow for some temporal changes to be found in that. And the reason for this is if we detect pervasive symptomology, we know that it can lead to higher levels of absenteeism, and then a reduction in patient care, and also heavier work burden on the remaining staff. So we really wanted to try and detect that. This slide just gives us a bit of an overview of the 2 time periods in which the measurements were taken. As you can see here, first measurement was taken in a relative lull of cases during COVID-19, basically mid-July to mid-August. 225 participants, quite a bit for NHS Highland. And then at time 2, 169. So we had 169 participants that completed both of the measurements. And the measurements were the validated questionnaires for depression, anxiety, well-being, and mental toughness. You can see here that time 2 was at the start of the second wave of the pandemic last year. So what we found, quite interesting, was that there were shifts in well-being, slightly lower rates of well-being time 2 compared to time 1. And we found something similar with anxiety, higher levels of anxiety at time 2 compared to time 1. Depression and well-being remaining quite similar. But if we categorize the measurements that we used, we can see that there were fewer people at time 2 that scored in the normal range of depression, and the same with anxiety. And we found the same to be true for well-being and for mental toughness. And this also says to us that our sample reported quite low levels of psychological well-being over a relatively long period of time, which is quite worrying. And then we also found that for these measures that we used, there were some fluctuations within individuals over time. And we saw that for depression, for anxiety, for well-being, and for mental toughness. But what is really interesting there is that we found mental toughness, which serves as an indicator for personal resilience, to be associated with temporal stability in the relationship with the other psychological measures over time. So that could potentially be something to target, because we see if mental toughness goes up, it creates a stabilizing effect over time. Then, and this is one of the nice parts about having longitudinal data, we found some risk factors that might be relevant if you looked at our study from, if you saw it as two cross-sectional studies. But what really stood out, even when accounting for demographic and professional variables as potential confounding factors, was that working directly with COVID-19 and the levels of disruption due to COVID-19 was what was really associated with changes in well-being and mental toughness and with depression. So those are, it basically says to us that COVID-19 was a risk factor on its own, and then disruption due to COVID-19 as well. Speaking about the third aim of our study, the 3-arm pilot RCT, we basically designed an app based on previously validated NHS used app, and we made it specific to our population and to our context. We introduced some narrative that works very well with the Highland setting and the rural setting, and we created a fictional character, a nurse named Iona, to guide participants through the app's modules, and then also to send them encouraging text to enhance engagement with the intervention. We had very good levels of engagement, and basically this project was a 4-week intervention designed to bolster psychological resilience and mental toughness, as we spoke about in the previous aim, and gratitude over the first 2 weeks, with the last 2 weeks focusing on dealing and coping effectively with low mood and anxiety. We then proceeded to compare our app, our intervention, to a validated NHS approved app, My Possible Self, and also to compare it to control, a waiting list condition. Don't worry, we did roll it out to the waiting list afterwards. So I think it was quite fair in the way that it was done. I'm just briefly going to speak about the results. I made it quite bold here. Look at the green line. That's the best way to look at this effect plot here. So we can see for well-being, our app increasing the well-being of our participants over 4 weeks and decreasing depression quite rapidly, and anxiety decreasing quite rapidly. Mental toughness showing an increase, as does gratitude. So what was statistically significant here was the reduction in anxiety compared to the other two groups. So that's really something to, we were quite surprised that was able to happen in 4 weeks. Yeah, so overall, we found that this pilot RCT found that the intervention was useful, statistically significantly for anxiety, but also useful for depression, well-being, mental toughness, and gratitude over time. In terms of impacts, there's quite a bit of news impact regarding the app, and then with the study overall, we know that we need to know what's happening to our staff's mental health, because it's likely to have an impact on the national response to the pandemic. We know that high levels of stress and anxiety will decrease staff morale, increase absenteeism, and it results in lower quality of care. Our research has also been used by in the Westminster Parliament for policy making, and I think very importantly, we've indicated that digital psychological interventions aimed at enhancing well-being can be of benefit, but I just want to reiterate that it should not be done at the expense of systemic interventions as well. For practice, I think we can see that we can quite rapidly employ these type of digital interventions. And the nice thing about that is it's anonymous, and that's something that healthcare workers want. And it's quite readily scalable as well. So we are definitely looking to implement this also in other health boards. We will look at doing that as the time goes on. We'll have some questions later, but for now, thank you for listening to me, and I'm going to hand over to Dr. Jenny Hall.
Thank you, Hannes. I just need to share my presentation as well. Good afternoon, everyone. The Rural Health and Wellbeing team have been working with NHS Highland for a number of years now on a new approach to reducing amputations in people with diabetes. We're all aware that the number of people with diabetes has been increasing globally, but to give you a sense of where we are in Scotland and the Highlands, it's estimated now that about 1 in 18 in Scotland and 1 in 17 people in Highland have diabetes. And of those people, just over 1 in 20 of them have had an ulcer, and 1 in 200 have had a lower limb amputation. And it's estimated that about 1 in 60 in Scotland and 1 in 70 in the Highlands has an active ulcer at any given time. While the Diabetes Survey, the Diabetes Register, is good at collecting information about who has diabetes, it doesn't collect as accurate information about ulcers. So these values are probably an underestimate as to the real numbers of people with ulcers. So what is it about diabetes that makes people more susceptible to developing ulcers and having amputations? Well, poorly managed diabetes ultimately leads to prolonged high blood glucose levels, which in turn can lead to peripheral nerve damage with loss of feeling. So people can't feel as much with on the soles of their feet. So a small cut can go unnoticed, and even an insignificant cut can develop into an ulcer and go on to become infected and subsequently lead to an amputation. Blood vessel damage is also caused by high blood glucose levels, which can lead to poor wound healing, which combined with the loss of healing exacerbates the effect, and you end up with potentially gangrenous areas that lead to requirement for amputations. Other risk factors are poor foot care, presence of foot deformities, being male, and also being a smoker. I think it's important to remember here that a majority of people with diabetes have type 2 diabetes. Type 2 diabetes is often diagnosed late, and this can mean that there's already a significant peripheral damage at the time of diagnosis, and so the risk of amputation can be very high. Clearly, ulcers and amputations have quality of life implications. They both substantially reduce health-related quality of life, and in fact, it's been estimated that the EQD5 scores, which is a self-reported quality of life, a standardized questionnaire, estimates that for people with ulcers, it's about 0.44 and about 0.31 for people with having had lower limb amputations. And these are lower scores than those recorded in people with breast cancer, prostate cancer, or end-stage renal disease. Mortality rates are also high with both ulcers and amputations. 5-year mortality after first amputation is estimated to be about 57%, and for diabetic foot ulcer about 30%. And this chart gives you an indication of where amputations fit in the whole scheme of mortality rates. So the pink one at the bottom here is breast cancer. The grey one at the top is lung cancer, and amputations sit below lung cancer, but diabetic foot ulcers sit sort of halfway in between. Obviously, as well as these high costs, so human costs, there's a significant cost implication to the NHS. The NHS spends about £1 billion on diabetes. 80% of that is spent treating potentially avoidable complications. It's estimated that about 1/5 of patients in hospital have diabetes, with foot ulceration and amputation being the leading cause of admission or diabetes-related admission. A third of direct costs for care in diabetes are due to lower extremity problems. And it's estimated that if you work on a £32,000 cost for a leg amputation and a year of aftercare, which is what the estimate currently is, that equates to about 4.9 million in Scotland based on the 2019 data, where there were 154 new lower limb amputations added to the register. And the important thing to remember here really is that up to 80% of amputations may be preventable. So what can we do to look at reducing risk of amputations? Well, obviously personal foot care is really important, and the importance of education and making daily checks is emphasised by sort of healthcare professionals. The NHS carries out regular foot screening to assess risk of developing foot ulcers, and rapid referral to a specialist team if diabetic foot disease is present is really important. But these present challenges for patients in rural settings, living perhaps distances from health resources, with transport limitations, and historically there's been a poor integration of community and specialist teams. So what is the aim of the rapid or the reducing amputations in people with diabetes pathway, and what does it look like? Well, the aim is to establish a care pathway system that allows early triage and appropriate follow-up. And the first bullet here, the increased timely referral to the multidisciplinary foot team, is the focus of the care pathway that we've been working with. If we look at the overview of the pathway, we have at the top left here a patient with diabetes and foot ulcer at home, seen by a community healthcare professional, referred in using a generic foot email account with photographs and a pro forma. This is checked or triaged by a diabetes specialist podiatrist within 24 hours, with an appropriate response by email, which might just be advice on wound review, but the focus of our follow-up in terms of technology and providing the resources closer to patients is this home or community clinic VC using NHS Near Me with the healthcare professional in attendance. These VC appointments are aimed at connecting the patient, community healthcare professional and the specialist team in Inverness. The technology uses mobile phone connectivity to enable healthcare professionals to use an iPad to connect with the VC with Near Me to provide that link with Inverness. 3 feasibility studies were carried out, and these showed that the technology provides good enough connectivity to support rollout. Acceptable photographs can be obtained and shared. Patients would be willing to use the service in the future, and the patients benefit through improved access. In terms of the outcomes of the feasibility, we had 117 visits, 63 consultations by VC. There were a number of technical failures for various reasons, some of which have been addressed. Patient experience, patients were very satisfied with the technology and the new pathway, and there were thousands of miles in patient travel saved. 87% of ulcers were healed, improved, or had no deterioration, and 3% minor amputations were seen compared to 7% as the average across NHS Highland for that within the time period. The projected costs were estimated to be a 50% reduction if the pathway was implemented, and healthcare professional input was included into fine-tuning the final pathway that has now been rolled out. The rollout started in May last year, and the community podiatrists across the Highlands in these areas have the kit, which is the Omni Hub, which showed you the iPad, and a laptop that they can use for connection back with Sky Diabetes and other healthcare databases. The Rural Health and Wellbeing team are carrying out an evaluation of the rollout, which is ongoing, having said it started last May. It's very early days. The numbers of people are quite low, so we have to run the evaluation for quite a long period of time to collect enough data to have confidence in what we're seeing. We're looking to add in a satellite option from a number of rural GP practices from June this year. That's to cover areas where perhaps there's been poor connectivity, so it gives the patients the option to go to their GP to do a similar VC consultation. As I said, the project has been running for some time. The clinical lead throughout has been Santa McCrory and Fiona Main, who's the diabetes specialist podiatrist. Dr. Janet Heaton and myself are the researchers working on it at the moment, but previous feasibility studies and work has been carried out by Dr. Anya Zabala and Kate Stephen. Okay, thank you very much. That's the end of what I have to say. I'll pass you on now to Anna, Dr. Anna Terge, a colleague, who's going to talk about the Empower project.
Thank you very much, Jenny, and good afternoon, everyone. So, sorry, I'm just the slides going. There we go. So today I'm going to give you a brief overview of how positive wellbeing outcomes can be achieved in rural areas using social prescribing, specifically making use of findings from the Empower evaluation. So Empower is a 5-year EU Interreg supported project that provides a service for over 65s with long-term conditions across the Republic of Ireland, Northern Ireland and Scotland, specifically in rural and remote regions. And it works with communities to enable people to live well, safely and independently in their own homes by self-managing their health and care in the community. So community navigators are employed to work with people referred from health and care services to develop wellbeing plans, connecting them to activities in their community, as well as connecting them to technology. And the Division of Rural Health and Wellbeing here at UHI is providing the evaluation for the programme. So from the evaluation we've conducted so far, 3 factors that support positive outcome achievement for beneficiaries of Empower emerged. Specifically, the importance of meetings taking place in the home setting, the amount of time spent with the beneficiary, and the manner of the interaction. So in terms of the manner of the interaction, beneficiaries reported that they felt community navigators were trustworthy and followed through, showed an overall high level of compassion and understanding, which builds trust. The second key aspect was the time community navigators spent with the beneficiary. The beneficiaries reported that community navigators not appearing to be in a rush, again, made them feel more relaxed and able to think things through. Beneficiaries also reported that being at home made them feel more comfortable and relaxed. Also, being in the home setting allowed community navigators to see the kind of environment that they live in and potentially identifying things that they may not have disclosed otherwise. Now, of course, during COVID, home visits have not been possible and interactions have mainly been taking place over the phone. It seems that to make up for this, community navigators are having to spend more time speaking to beneficiaries to build trust using their skills in guided conversations and empathy. So this relationship really is the foundation of generation of positive outcomes of Empower, and it can't be separated from the impact of taking part in social activities or increasing digital literacy. And in fact, many beneficiaries reported that it was this interaction in itself that was the most valued part of the service, just being able to talk about their health and well-being in a holistic manner. So we'll now turn to the 2 main outcomes that for beneficiaries that we identified, namely increases in confidence and empowerment and reduction in loneliness and social isolation. So beneficiaries often simply find it difficult to know where to start, and the community navigator could be instrumental in providing the encouragement needed to take that first step and empower people to get more active. Taking part in physical activity classes could improve confidence, as well as having a social aspect to it. So here's a quote from one of the beneficiaries who talks about how their confidence, physical health and also their kind of social lives have improved by taking part in an exercise class. And beneficiaries becoming more digitally literate was also important in terms of empowerment. Help them keep in touch with family. It can be often far away when you live rurally. And over the past year, of course, there's been increased support to help beneficiaries keep in touch with family and friends, both near and far. So in terms of decreased isolation and loneliness, many beneficiaries acknowledge that ways of being socially have changed, and this is often particularly felt by those over the age of 65. Here we have a quote from a beneficiary who talks about missing how people would congregate in houses in the evenings and chat in the 50s and 60s, and that's not really taking place anymore, and that's why services like befriending and social prescribing are important. And furthermore, the loss of local services in rural and remote areas, natural places for social interaction were lost. So community navigators could help beneficiaries find new ways of being socially and new spaces for social interaction. And during COVID, community navigators have found new ways for beneficiaries to engage, for example, by using telephone befriending services and pen pals. So the approach to service delivery that we talked about earlier really creates an environment that's conducive for building trust. And some beneficiaries could be hesitant to open up about being lonely, but as trust was being built, they were often able to. Also, supporting using phones and tablets to text and use Zoom played an important role in reducing loneliness, as this enabled beneficiaries to keep in touch. And finally, we should say that those who are the most lonely and potentially the most in need of a service like Empower may also be the hardest to reach. So just to summarize, the relationship between the community navigator and beneficiary is really key for positive program outcomes, and this goes beyond signposting. And engagement with the program also increases confidence and a sense of empowerment as a result of tools employed by community navigators and a creative and person-centered approach. And reduction in feelings of loneliness and isolation was the most frequently reported outcome. And this shows the importance of group activities and increases in digital literacy. So thank you very much. I will now hand over to Dr. Anya Zubala.
Thank you, Anna, and hello, everyone. I'd like to tell you today about how research at UHI is supporting the development of novel evidence-based art therapy interventions that are tailored to the needs of local communities in the Highlands and Islands. I don't seem to be able to change slides. Jill, could you help?
Yes, just tell me when you want to move them. Try again, but if it doesn't work, let me know.
It's working now, thank you. If you are not familiar with art therapy, it is helpful to think about it as a form of psychotherapy that uses art media as a primary mode of expression and communication. Art therapists are highly qualified allied health professionals trained at the postgraduate level and bound by professional code of ethics. Documented benefits of art therapy are multiple and include improvements in all areas of psychological well-being, such as self-confidence, mood, resilience, and many others. Since art therapy has both curative and preventative potential, clients who do not experience specific mental health difficulties might also use art therapy to increase their quality of life and enhance well-being. In Scotland, art therapy is rarely available to people living in rural or remote locations, as services are predominantly centered around urban areas and delivered face-to-face. In fact, access to art therapy nowadays might be more limited than it used to be 70 years ago, when Scotland was at the forefront of development of this unique profession. Online delivery might increase access to art therapy and offer more privacy, which might be particularly welcomed by clients living in small communities. Can I have next slide, please? Jill, could you please help? I don't seem to be able to change slides for some reason.
Okay, I've just moved it on. Do you want me to move it on again?
Yes, please, yeah. Apologies for that. In our recent review, we found that art therapy discipline has increasingly welcomed opportunities offered by digital technology for both online connectivity and digital art making. And most recently, like so many other health professions, art therapy embraced online practice as a means to ensure continuity of treatment for clients. And we felt that documenting and supporting this rapid change in practice through research is vital. Can I have next slide, please?
Has that moved on for you?
Yes, thank you. Last summer, we ran an online survey of UK-based art therapists to better understand their early experiences of what was often felt like a forced transition to online practice. And we found that nearly 90% of respondents provided online art therapy at that time, of whom 87% have been doing this only since March 2020. Importantly, the vast majority of respondents reported that they intended to honor their clients' preferences for mode of delivery in the future, and it may be expected that as many as 90% therapists will continue offering online art therapy beyond the current necessity of the pandemic. Can I please have the next slide? Thank you. We also invited art therapists to share their artistic responses to the sudden change in practice. And this particular image was titled "Hummingbird being drained out of color and weighted down by corona boots." And I imagine it might resemble the burden of responsibility felt by art therapists as they strive to continue offering a safe space for their clients in virtual environments. And these environments are often far more difficult to control and not necessarily naturally conducive to supporting the therapeutic process and self-expression. Next slide, please. Indeed, early findings from our survey confirm that client safety is a key priority for art therapists, and it sheds light on solutions that they devised and adopted very quickly, as well as on the challenges that they encountered. Some of these are likely shared by all health professionals delivering services remotely, while others are specific to art therapy practice. For example, therapeutic relationship in art therapy is threefold. It involves not only the client and the therapist as in verbal psychotherapies, but also the process of art making and the artwork itself. Online practice, therefore, needs bespoke solutions to work with and safely share and store images, both created digitally and with traditional arts media. Our future research will explore this and other aspects of online, rural, and distance art therapy practice. We will soon conduct interviews with art therapists who work in remote and rural locations to identify areas of key priorities for future research. Consultations will then follow with experts in art psychotherapy services design, delivery of healthcare, of telehealthcare, and innovative technologies. We are currently designing a pilot of online art therapy service to be offered in the next couple of months to residents in the Western Isles. We will establish the need, acceptability, and feasibility of such a service. And this will also be the time to learn from clients about their experiences, an absolutely vital element that is still missing from research to date. I'd like to leave you with a couple of expressions. This is how art therapists in our survey describe their feelings in connection with online practice. And some of these words might just as well describe the research process, but I wouldn't really want to have it any other way. Many thanks for listening, and please do get in touch with any questions or ideas on this subject. Thank you.
Thank you very much, Anya, and thank you, Anna, Jenny, Hannes, and Sarah Ann as well for some really thought-provoking and pieces of research and work that you're all doing, all work that's all needed, I'm sure. Definitely leading rural health, as the title of this event rightly states. So forgive me for not doing the Gaelic. I come from the Scottish borders, and it's a wee while since we spoke Gaelic down there. So, but anyway, thank you very much to all the presenters. I think it's we've had a couple of questions go into the Q&A. We'll come to those after we've heard from the expert panel. So in order that's on my agenda anyway, could we have some observations and thoughts from Moira Mckenzie to be followed by Professor Arthur Steiner. So Moira, do you have some thoughts and observations on some of these presentations today?
Yeah, thanks, Jim. I mean, fascinating stuff coming through there. Some of it which I was already aware of, but some definitely new to me. So it makes me reflect that, you know, very often Highlands and Islands are pretty much the creative influence for the rest of Scotland, if not globally. So I can see some evidence of that coming through again. Particularly interested in the work that Sarah Ann was sharing round about the kind of collaborative planning, because again, much of the work that we do in DHI is about scoping new pathways and ways of engaging and co-designing with people. So some really interesting learning coming through there. With regard to kind of mental health apps, I would say, and I'm sure Hannes is already aware of this, that there are literally hundreds of thousands of apps in the health space, and particularly strong on the mental health side. And the challenges are more to do with integration of the apps within wider systems, assurance processes, various other elements of that. So again, fascinated to see how that develops beyond, and whether the adherence and the impact of the app was sustained beyond a 4-week period. I mean, again, a lot of this is fairly new to people, so they do adhere more at the beginning, but that kind of tends to fall off from the experience that we've had. So again, interested to see how that's sustained. And the virtual clinic side, and particularly on things like the diabetes, the diabetic foot ulcers, loads of impact coming through from the use of these virtual clinics. I think the key bit there was the connectivity offered by the satellite connections, which is making the difference within, you know, kind of remote and rural connections. So again, really interesting to see how that can extend further. And the community, what always strikes me with some of these initiatives is very much the business case that might sit behind them. So what we have to do, because we have obviously got limited funding and resource available within our public health and care systems, is how, by what we're doing with these more creative approaches, does it replace and provide alternatives for services that are already there. So there's very much a kind of cost benefit analysis that needs to be undertaken to maybe move them up to the next level. But Jim, that was the kind of main ones from me.
Thanks very much for that, Moira. It would be good to hear from Professor Arthur Steiner, and then after that, Dr. Kate Stevens. Arthur, there's a couple of thoughts, especially relating to perhaps, of course, in the pandemic at the moment, and obviously looking for places to focus. So Arthur, would you have some comments at the moment?
Yes, of course, thank you. Well, first of all, congratulations to all presenters, because I think you proved the variety of rural research that you're conducting within UHI, and congratulations also to UHI for conducting world-leading research. And as we could hear, for example, from Saran, that components of research that were conducted in the Scottish Highlands by UHI traveled on to the other side of the planet, to Australia, and that really is a proof that the research that you conduct is absolutely amazing and is obviously appreciated elsewhere in other parts of the world. In relation to different presentations, I think what is really interesting is that we can see a variety of research that is conducted as a response to current challenges like COVID challenges. So it shows that researchers, we as researchers, we have to be really reactive and provide answers and analyze things, what's happening right now, but also other research activities could show that there are some embedded problems in rural health and care service provision when it comes to, for example, well-being of people. And those are kind of problems that are quite persistent. And again, research activities can help to address certain aspects, and the new interventions can verify what works, what doesn't. And I think here you've got a great testimony to show that, for example, new technology can be used to address a lot of problems embedded within the society, which obviously is extremely exciting if we think about how technology develops and how we can use it for health purposes, but also, the kind of traditional mental health and well-being and aspects associated with community cohesion, social capital, how important that is to provide well-being services, reduce social isolation and related matters. So I think, yeah, those are kind of key points And yeah, I look forward to discussing and answering questions of the audience. Thank you.
Thank you very much, Arthur. Thanks for those observations and comments. Dr. Kate Stephen of Scotland Rural College, SRUC, and then of course we'll come to James Cameron. So Kate.
Hi everybody. Yes, like the other two panelists, I really enjoyed all the presentations. A great diversity and very interesting. I thought there were some themes that were coming through, and there was almost like two pictures of the pre-digital, pre-COVID situation where patients travel to get to appointments, and that means often it's detrimental to them, especially if they've got a foot ulcer, for example, but also the fact that they'll maybe travel a lot of miles and a lot of time involved in it, a lot of cost to themselves, and then they get to a short appointment which is maybe a bit rushed. And also I think in that picture are staff that are travelling from their rural homes around the Highlands and Islands to get to the kind of clinical centre. And on the other side of the picture then was the idea of having a local person who had time, and they had time to encourage you and not to be rushed, and how that seemed to be such a positive and welcomed aspect of it, and even for people who maybe weren't used to using technology and their digital literacy was very, very low, I think that having a local kind person encouraging you to either exercise or to go online seem to have a lot of benefits. And so I think that it's interesting that there's sometimes a lot of resistance to the use of technology for delivering healthcare services, and a little bit of cynicism that actually it's about using technology where human beings are less available. And I think instead of that scenario, that what's painted here is a kind of different scenario where there are human beings, but it's maybe different people, and actually the interaction between the local health practitioner and our support worker or connector and the patient or has more quality and more value in a way that may be good for their health and well-being, as well as the kind of clinical input that they're getting through technology. Thank you.
Thank you very much for that, Kate, as well. And finally, before we go to the questions that have been submitted, James Cameron from Highlands and Islands Enterprise. It'd be interesting to hear your thoughts.
Yeah, thanks, Jim. Again, as has been mentioned, it's been a really fascinating series of presentations there with covering so many areas. For me, in the job that I do in Highlands and Islands, that's trying to grow and sustain our remote and rural communities, as well as the Inverness and the bigger communities. So all of it is vitally important to us, and I do think that my engagement is with businesses, and the businesses need to engage with researchers and clinicians in order to build confidence, to help shape and to create jobs and opportunities throughout the Highlands. I'm really taken by Dr. Jenny Hall's presentation. We run a UK-wide seminar on Monday there. We limited the number of presentations to 10, and 6 of those were diabetes related. The challenge, personally speaking, is getting things procured and adopted by the health and care service. So that's the bit that I find one of the big challenges. And if we can overcome that, not only do we have great world-leading research, we should have world-leading adoption as well, and that really does raise the flag for our area.
Thanks very much for that, James. That's really great. Thanks for all the panelists for giving us observations. Now, we do have a few questions in already, so I remind attendees to pop any more questions in the Q&A, and we'll look to get some of these answered. I think this one might be useful to hear from Sarah Ann Minoz, particularly as her presentation was on designing sustainable rural health services. We need, of course, staff to do that. So the question is, and then maybe James Cameron as well, because you have inward investment in your title, so you maybe have a comment or not, but it might be interesting. And if other panelists want to chip in, then please get my attention, and we can do that. So the question is, if the panelists and presenters could comment on retention and recruitment of health professionals in rural areas, and if they have any research in this area or insight they could give. So Sarah Ann Minoz, sorry to come to you first, but is there research in this area at the moment, Sarah Ann?
Yeah, there is definitely research in this area, and some that rural health and wellbeing have been involved in, and more widely within Highlands and Islands that NHS Highland have been leading as well. I guess from our side, we've been involved in a large scale evaluation around primary care provision within NHS Highlands, and that definitely touched on these issues around recruitment and retention of healthcare professionals, which I think is the person who's asked the questions kind of implied. It's really essential that you have the staff to be able to maintain the service. I think it's a really complex mixture of things that influence whether a healthcare professional comes to work in a rural area. From our research, you've seen it's like a mixture of that individual's background, their course through medical education, and whether that's had a rural component within it, through to much more personal circumstances, such as people considering the employment of their spouse, or whether they can get affordable housing within a rural community. So I think it's a really complex picture. I think some of the things that people talk to us about in terms of being successful were when posts were advertised that really promoted the challenging and kind of interesting nature of work that you can get in rural areas, but also provided some context, often around kind of what a local facilities might be like and what training might be like. So it's a really complex picture, but we can certainly share some findings from evaluation and from those wider NHS Highland initiatives as well, if people would be interested.
Thanks very much for that, Sarah. And sorry to be James Cameron on the spot, but unfortunately you've got inward investment in your blurb and your biography, and of course we need inward investment of health professionals. So I wonder if, James, you had any thoughts on that point made about health professionals.
Yeah, Jim, just building on Sarah's to an extent, but one of the quotes that came out from an inward investor on Monday was quite simply, digital health significantly changes who does what going forward. So in a way, there is the professionals. How do you create headspace for those professionals to get the time to do interesting research that would be really beneficial, and is one way. So the job has to be attractive on a whole bunch of things. But there's also who are the, it's a broad spectrum of health and care professionals, from the GPs through to all frontline people. So I think in terms of that, I think understanding how technology and digital health and diagnostics can make a difference and make the jobs more interesting and current, and really become more global, to be honest, Jim, I think.
That's great, and that kind of leads into Moira Mckenzie, digital health. That's your big thing there, Moira. Is digital health going to help if there is a problem of retaining and recruiting health professionals, a different way of delivering health, Moira?
Yeah, I think so. I think again, you know, if nothing else, the COVID environment has changed the game fairly significantly, and you know, a lot of the work that UHI have been doing has almost come before that and informed and probably created quite a good foundation for some of the work that then kicked off. So if you consider that the virtual clinics that were rolled out near me was named in Highland, you know, so again, there's quite a lot of impact already been made round about the establishment of things like virtual clinics. And what that does practically is reduce the need to travel, as we know. So it reduces the need for the service user, the patient, to travel, but it also reduces the need for the health professional to travel, and it also increases productivity. So the number of patients you can see in the course of a day changes fairly significantly if you're not having to travel out to those patients and those patients aren't having to travel to you. So some of those things round about job satisfaction and reach are definitely affected by the use of digital tools that help keep you connected to your patient base and you're doing your rounds in a different way. So I do think, you know, as I started out saying, I do think that has changed the game significantly during COVID. I would like to think that we take the positives from that and we continue to do that and continue to roll it out as we go forward as well. You're on mute, Jim.
Oh, I'm on mute. No, I'm not on mute. It says hopefully you hear me okay. Yeah, no, thanks for that. I think somebody tried to mute me as I unmute myself, and we got into that whole downward spiral of the mute and mute thing. So I have ordered my T-shirt for post-COVID where it will say on the side I'm on mute, so it might be quite handy in the future. But anyway, thanks for that. We'll probably rattle on. We'll try and get an answer to a couple more questions that we have in. Probably not any more time to take any more of those questions. And I think, Anu Zawala, I think you'll be in the prime location to answer this question. And it's from Isabel McLeish. Would you comment on the role of arts health research projects for the future of rural health? I'm sure Anya will, such as arts research projects that use participatory action research and involve practice-led research in rural areas. Does the UHI Rural Health and Wellbeing Department currently explore and use arts-based research methodologies? So Anya, I'm going to put you on the spot for that.
Thank you, Jim. Yes, thanks so much for this interesting question, and I can confirm that yes, we engage in arts-based research methods. Certainly, I think in the particular context of rural and more remote areas of the Highlands and Islands, arts-based research has this benefit of being a very equalizing type of research methodology. Arts generally are very universal, something that everyone can engage with. And I think in the context of rural health and rural and remote practice of health practitioners, there's something important about everyone being able to be involved in service design, in service development, and advanced service provision, including the patients themselves, their families, policymakers, and of course us researchers. So there's something about arts-based methodologies that allows us to create those equal spaces for engagement, which is very very important. And the area of arts and health, I feel is very close to the hearts of many people in the Scottish Highlands and Islands. Scottish Highlands and Islands communities are immensely creative in many different ways, and I think it's really important for us researchers to be able to harness this creativity and to work with people based on this, and to be able to understand people's motivations, experiences, wishes, you know, and plans through arts. So I think that there's something important in arts about being able to connect, and that's what I think we as researchers would like to do. We would like to connect with local communities on all levels. So yes, I think it's very important. Thank you.
Yeah, no, thanks for that, Anya. Hannes de Kock, Doctor. Obviously, you work with mental health, and you've been developing an app, which I'm sure, as you can see, has been very successful. Perhaps a comment on yourself on art therapy and helping people with their poor mental health as well. Is that something that is of interest in your research and work and findings as a clinical psychologist?
Yeah, I mean, look, I think as well as an app can do, it can only do so much. And we know that art has the capacity for real connection between different parts of the self, but also between different people. And that's really what you want to increase psychological well-being. So I would definitely back up what Anya said there, and say there's a future for art and art therapies.
Thanks very much. Thanks very much for that, Hannes. We are getting nearer our time, so we'll probably leak over a little bit. We do have one final question, which I'll ask to the panelists and presenters who haven't already answered the question. And it is, as we are currently living through a pandemic, can the panel identify their top 2 areas, one will do, but 2 if you can, that should ideally be focused on by governments and researchers to develop policy to promote remote and rural health and social care recovery and remobilisation? So I'm going to pick on Kate Stephen. Dr. Kate Stephen, would you like to comment on that first? And then we'll maybe go to Anna Terry after that.
My top one would be digital infrastructure, because with most of the presentations, good connectivity is central to the success of this working. And clearly there are some areas in the Highlands and Islands where people really struggle with a digital connection. And so for me, if I had a magic wand, I think having a really good digital connectivity across remote and rural areas would transform a lot of people's lives and transform the economy in the rural areas. And then, so that would be my first one. And then followed behind that again is just a kind of a core level of infrastructure, because if it's connected to the question about staff coming to the Highlands and Islands, people will be reluctant to come to a place if the roads are bad and there's not educational provision that they can rely on, and there's not enough kind of infrastructure to support their lives. So infrastructure is the main theme, digital is the first one, and then just a really decent level of infrastructure for remote and rural communities.
Thanks very much for that, Kate. I think we'll have Anna Terry next, and then Jenny, then Arthur. So Anna.
Thanks, Jim. Well, I definitely agree with Kate in terms of the connectivity in particular, because that is a real issue, and it creates inequalities what people have access to. I think what I would say, perhaps leading on from the research that I presented, and there is more investment in the third sector, because if we're moving towards a model of care in the community and more kind of preventative care to improve people's well-being, if the kind of burden to deliver that lies with the third sector, we need to invest in the third sector. We can't expect it to just be taken care of. So I think, yeah, that would be my top one.
And thanks very much for that as well, Anna. Thank you. It's great. Jenny Hall, and then maybe Arthur Steiner, the last word.
I think I'm probably going to echo Kate and Anna's comments in terms of infrastructure for connectivity, but probably add in a comment about sustaining that accessibility that has been forced upon us through the COVID pandemic. There are a lot of people who would not normally be able to access, whether that's through poor connectivity or through the way services are delivered in urban areas. Trying to ensure that the drive that has been there and with the systems put in place for people to access services through the pandemic is not forgotten about when people are able to go face to face and access things in rather than in the virtual world. Because I think it did create a level playing field for many people who are normally unable to access things. So I guess that's where it's sustaining that level of access, which has an underlying infrastructure component to it.
Thank you very much for that. And Professor Steiner, Arthur, some comments or some points in areas that should ideally be focused on by government and researchers. I'm sure you'll have a few points on that.
Yes, well, obviously there is a pattern already emerging there in terms of online technology, and I think obviously COVID-19 pandemic I think accelerated certain processes, and online technology became widely acceptable, but also socially acceptable because people were nearly forced to use it, and I think we got used to using it in so many different ways, so it became part of our daily life. So I think we need to take advantage of it and move things forward into that direction. As we talk about, health professionals, they don't need to be based in rural locations. They can be, quite far away, and we have to utilize those resources to increase efficiency, to increase patient experience, improve patients' experiences, to provide quick services. So there is a massive area there that needs to be definitely explored and harnessed. And the other probably dimension, I would say something associated with investing in capacity and social capital of rural communities. We know that rural communities very often tend to be supportive, but also we know about the changing kind of dimensions and picture of rural communities, where sometimes certain connections are lost because rural communities in the past used to have the same set of residents, used to have lots of farmers, and sometimes these days you've got people having second homes, or people coming and just sleeping in a village and then traveling to the city, and certain connections is lost. And I think investing in this kind of social community kind of projects is really important to bring people together, so the self-help is still maintained over the course of many years, and years to come. Thank you.
No, thank you very much, Arthur, and just thank everybody. Of course, that's we have run over in just a few minutes, so can I first of all thank the presenters for firstly being on time and making my job as a chairperson very easy indeed. So thank you very much to Dr. Anya Zubala, Dr. Anna Teria, Dr. Jenny Hall, of course, Dr. Hannes de Kirk, and Professor Sarah Ann Manoz for the presentations, and of course our panel members as well, and James Cameron from Highlands and Islands Enterprise, Dr. Arthur Steiner from Glasgow Cala Uni, and Dr. Kate Stephen of SRUC, and of course Moira Mckenzie from Deputy Chief Exec of the Digital Health and Care Innovation Centre for some really leading events, leading subjects, I should say, and leading the field for sure in rural health. So thank you very much to all of you. As you can see from this slide, this is not the last of these leading events by the University of Highlands Islands for their 10th anniversary. We have another one on the 13th of May, again at 4 o'clock to 5:15. And if you want to book your tickets for that, you can go online to see how to do that on uhi.ac.uk/events. So thank you very much, and thank you all for attending today, coming along. I'm sure you've all got some real food for thought going home. And from now, let's see further actions, and I'm sure, and it's everyone's business, of course, to tackle health as best we can. So thank you very much. There will be a follow-up survey coming along to be confirmed. But the next event will discuss the future of learning from an education and the University of Highlands and Islands perspective. It will also highlight how creative subjects such as music, we've talked about art, can be successfully delivered online via the university's network. So as I said, if you're interested in the Leading Learning event, that's at uhi.ac.uk/events. Thank you very much, and just keep safe, keep well, and hope to see you very soon again. Bye.
Okay, bye.